Welcome to the Heads Up podcast, brought to you by the National Migraine Centre, the only UK charity treating headache and migraine. Visit our website to book your appointment with a world-class headache doctor wherever you are in the UK. There is no need for a referral. You can refer yourself. Our headache specialist doctors are looking forward to helping you soon.
Hello, everybody, and welcome to this episode of the Heads Up podcast. We are focusing in today on a condition which is very different from migraine, but also has some similarities, and that is cluster headache. And we have already done a couple of episodes about the clinical aspects of cluster headache, but I thought it would be lovely to welcome back Dr. Phil Holland, who has done a wonderful podcast episode with me before on the science of migraine. And Phil is here today to speak to me about cluster headache and what's happening in the brain and get a bit more of a sense of the biology and the neurological processes that are going on, and to talk to us a little bit about research and what questions we need to be asking and what sort of things might we be understanding in the future. So welcome, Phil. Do you want to introduce yourself again?
Yeah, I think first just to say thank you very much for having me back. Obviously, the first episode of Migraine must have went well, and encourage people to go listen to that if they have an interest in the science of migraine. So I'm Phil Holland. I lead a research group at King's College London. For a number of years now, I've been interested in an array of primary headache disorders, so migraine, cluster headache. Work very closely with some clinical colleagues, including Katy here, of course, who hosts BASH. We've been involved in BASH, that's the British Association for the Study of Headache, for a number of years, and really getting interested in cluster headache biology and trying to understand the mechanisms of that disease. When I'm not sort of doing the science, so to speak, and running a laboratory, I'm an editor for a number of journals, so making sure that the work that's been done has been published and people can see the great research that's happening in these areas. And I'm also a board member and president-elect of the European Headache Federation, so really trying to fight to push awareness for headache disorders across Europe.
Thanks, Phil. And I have to say, one of the reasons I've invited Phil back is because he's one of the clearest guests that I've had and explains things in such a nice, accessible way. So let's get delving into cluster headache, Phil. So it's a different condition from migraine, but there are some features that are shared between these two conditions. So in our previous episodes about cluster headache, we've talked a lot about how you diagnose it. But do you want to just outline what you think, where we should be starting when we're talking about cluster headache and what's happening in the brain?
Yeah, so I think really for me, the interest is around looking at what's happening clinically and trying to understand what that means for the disease in terms of what's happening in the brain, how we can come up with new treatments, new strategies to intervene there. And while migraine, of course, is this, moderate to severe head pain, often throbbing, unilateral. And of course, cluster headache, again, is a pain in the head. In fact, it's described as one of the most severe pains known to humankind. I mean, so we can really say that cluster headache is ranked there as one of the most severe pains. So it's very clear to us that these shared pain pathways exist between migraine and cluster headache. However, the pain often presents in a different way, where now people will explain the pain is very localized around, for example, an eye. And one particular description that's struck with me from a patient interview I use when teaching is about the gentleman's explaining that it feels like somebody's drilling through his eyeball with a hot drill, and that really close. And that also explains why patients will get this tearing in the eye and the reddening around the eye, and these sort of what we call cranial autonomic features. So these things that they'll experience. And again, while those events can happen in migraine, it tends to be in the more severe cases of migraine, whereas for cluster headache, they're actually a hallmark of the disease. And I think really interestingly, from a science perspective, if you have a migrainous biology and you're having a migraine attack, you want to go withdraw from the world and come away from sensory stimuli and go to a dark room, sit in a quiet corner. Whereas with cluster headache, people often get very restless and agitated. So you'll see the patients much more agitated and moving. So really a very clear hallmark there in terms of distinguishing the two conditions. And then again, we have the very obvious, we may talk about this later, but cluster headache has this very striking circadian and circannual pattern. That's so when the attacks are happening at specific times of the day and specific times of the year. A really striking phenomenon that, again, that's shared with migraine, but much more prominent in cluster headache.
Yes, I think that's really helpful to outline those things, because when you have a patient who has had migraine for some years, they sometimes will also develop symptoms of cluster headache. And one of the things they come in and say is, this is very different from my migraine attacks. And I had somebody the other day saying to me, these attacks come on, the pain is so excruciating, it comes on instantaneously. It's always on one side of the head. And we know with migraine, it's sometimes on one side, sometimes the other side. Sometimes it can move between the sides, but with cluster headache, it tends to be fixed on one side of the head. So I asked him, what do you do when you get a cluster headache attack? And he said to me, well, I normally with his migraine attacks, he would go and lie down in a dark room. But he said, I couldn't do that during these new attacks. I had to pace about, and the agitation was very evident, and two very different headache types became evident then. But of course, some people with because migraine's so common, some people with migraine will develop cluster headache, but not everybody with cluster headache has migraine. So do we feel that this is a sort of a spectrum condition between migraine and cluster headache, or what do we think about that?
I think certainly at the biological level, for me, they're very clearly two separate entities, but with shared biology is how I would describe them in that context. And it's interesting you say that, actually, because in the migraine episode, we probably discussed that I've got 5 sisters. So, of course, with migraine being more common in women, and cluster headache now being more common in men, so showing that sort of opposite sex difference. And actually, my twin sister, who suffer from a form of migraine with hemiplegia, has now actually started to transition slightly towards cluster headache also. So she occasionally has seen these very clear seasonal bouts, very cluster headache specific. So it's something I'm acutely aware of, that people can transition.
Yeah. Well, bad luck for her. Well, at least she has you as a brother to sort out the answers. So what is going on in the brain in a cluster headache attack then? I'm so interested in, why does it occur around the same time? Why does it occur around the same season? Why is the pain so severe? I mean, there's so many questions. Can you answer all or any of them, Phil?
So I think the first one is really around, and it's a really intriguing question for us, is why attacks, or bouts as we call them, these bouts of cluster attacks, why they happen. And people will recognise that things that may trigger their attacks when they're in bout won't necessarily trigger an attack when they're out of bout. And the science backs that up. If we try and trigger patients out of bout, we don't see a success there. It's really when they're in bout. So there's something fundamental different in the brain. And when I'm trying to explain this between my students, I kind of say that with migraine, for example, you have the migraine biology, and it's like a threshold disorder. Yeah. So stress, things can build that threshold, and you can tip into an attack at any time if the conditions are right.
Yeah.
Whereas with cluster headache, it very much appears like there's a switch.
Uh-huh.
And this is now an on and off switch that's really affected by the seasons. So some lovely work by Danish colleagues, Rigmor Jensen and colleagues, who showed that the occurrence of cluster headache was inversely related to daylight length. So lower daylight length, you're more likely to get attacks. So this suggests that there's this link between cluster headache and the amount of daylight exposure you're having and those seasonal changes. And I think that's why we see these rhythmic bouts in individuals. And it's important to say that while we say a lot of these attacks can happen, around September, for example, is a very common month for these, it can be different in each individual. But when you look at the population level, you seem to have these seasonal bouts. So we certainly think that daylight length has a big impact on this. And then, of course, within an individual, we get this situation where many individuals can really predict when these attacks are going to happen. And that's in some way where that phrase of alarm clock headache came from, because there was this regular attack onset after sleep. And at that time, it was actually thought that it might be linked to a specific state of sleep called rapid eye movement sleep. So it's a type of sleep that we do. And actually, future studies now have shown that that's not the case. But it's going to be really interesting to understand what is it about sleep, because also in these patients, daytime naps can bring on attacks. So what is it about sleep that might be bringing on these attacks? Whereas in the comparison with migraine, of course, sleep and daytime naps is often used as a coping strategy. So that's what I mean about them being different entities. There's these very clear distinguishing factors, I think, that are really important for individuals to know about.
One of the things I'm aware of from listening to patients is some patients and I had somebody the other day who'd never really seen a doctor, but he had managed his cluster headaches by buying over-the-counter melatonin. And although he hadn't had an official diagnosis or any kind of assessment by a headache specialist, he had found that taking a dose of melatonin around the time that he was usually getting his cluster headache bout had really helped to reduce the impact of it. And the other thing I'm aware of is vitamin D, and people talking about vitamin D in high doses to manage cluster headache. And of course, vitamin D is so linked with daylight because we make it in our skin during the sunny days. So yeah, it's so fascinating.
Yeah, so I think maybe to start actually with the melatonin one, it's a very interesting molecule, because melatonin, release is suppressed by daylight. Essentially, daylight suppresses melatonin release, and then it's released as late evening as we go to sleep. So, of course, you've got these daily changes in the levels of melatonin. And, of course, those melatonin peaks can be blunted, so they can be reduced in patients. So there's definitely some evidence there for an involvement. There's not a lot of clinical evidence. There is some clinical evidence out there that it can help, for example, when co-administered with verapamil is one of the treatments for cluster headache. There's a bit of evidence out there around melatonin. And actually, we've been doing a bit of work in the laboratory recently about trying to understand how melatonin might be working in cluster headache. And I think it's a really interesting area, actually, going forward. Of course, available over the counter in the US, for example, but technically prescription in the UK for healthcare purposes. And then vitamin D, that actually is a really striking one, because there is literature there showing that people with cluster headache can have sort of vitamin and nutrient deficiencies, vitamin D being one of them, other things like magnesium and zinc. And of course, as you mentioned, our skin essentially makes vitamin D through exposure, but that only happens during the summer longer days where we have the strength of the sun. And it really somewhere in the region of 30 minutes to an hour of sun exposure a day to produce the levels we need. And in the winter, of course, often the level of sunlight just isn't strong enough. So actually, people, even away from cluster headache, need to think then about supplementation during those winter months. So again, it could be a combination, thinking back to what we said just a minute ago about that change in daylight length. You've got the change in daylight length, which is going to affect your circadian ability. That's the entrainment of your biological clock, your body, to the light-dark cycles, which is going to change. But also, you're going to be producing much less vitamin D, for example. So, and given these nutrients are, low risk, very affordable in some ways, again, it's certainly a good place to look.
That makes me wonder if there is research going on into geography, because if you live in Finland and you've got 24-hour nighttime during the winter and 24-hour sunshine during the summer, or if you live at the equator where you have even amounts of, is there a difference in the incidence of cluster headache in different geographical areas because of the different in day length?
Yeah, I think it's a really interesting question. And I think the first problem here is to say that a lot of that research hasn't really been done properly yet. And I think that comes back to the fact that one of the reasons I got interested in cluster headache was because actually we often refer it to as a rarer headache. It's a rare headache compared to migraine, for example. But it's as common in the UK as multiple sclerosis, 1 in 1,000 people, for example, in these high prevalence MS places like UK or US. So it's not actually, so it's caught in one of those kind of middle spaces where it's not as common as migraine, but it's not a rare disease, where a lot of funding goes to look at rare diseases, and cluster headache somehow finds itself in a bit of a grey area for research. And I think that's something we need to really address in terms of awareness, exposure, and push for this kind of research whereby, these patients are very active. When you do seek their help, they're very engaging and want to take part in studies to understand what's going on in the brain, for example. And we have a colleague who's just joined us who's going to be working, actually, some very, very kind patients through the Dutch Brain Bank have donated their brains. And we're looking at, for example, what's been happening inside those brains in cluster headache patients versus migraine brains versus control patients. So it's going to be really interesting to try and dissect what's happening inside these structures.
So we know in migraine, we know that there are certain neuropeptides that are really important. And one of the ones that's led on to really life-changing new medications is the calcitonin gene-related peptide, and the way that we can block that now with some of our medications. Is CGRP important in cluster headache?
Yeah, so again, I think there are some CGRP blocking agents, so molecules that can reduce the actions of this calcitonin gene-related peptide, and they've been approved clinically now for the treatment of episodic cluster headache, of course, in that way. I think one of the interesting things, we spoke about cluster headache and migraine being different entities with shared biology. Yeah. And I think that tells us that some of the shared biology of pain processing, there's evidence that these CGRP drugs can reduce that. What we've done in the past, and this was what we done a number of years ago, is that in cluster headache, we have this second pathway again. Rather than a pathway that's taking the pain signal from the head to the brain, we have this pathway from the brain to the head, which is involved in these autonomic symptoms, the lacrimation, the tearing of the eye, the facial flushing and sweating. And it seems that calcitonin gene-related peptide is much less involved in that pathway, but there is a related neuropeptide, so a different molecule now. This one is a really complex name. It's called pituitary adenylate cyclase activating polypeptide, PACAP for short.
Much easier to remember.
Much easier to remember. So just remember PACAP. And while we're not quite there yet, the evidence suggests that this will be a really interesting molecule with effects in cluster headache. And this molecule has just passed phase 2 clinical trial for migraine, actually. So it was able to show a beneficial effect also for migraine in episodic migraine. So there's a chance that these molecules that are in development may one day be able to give us an even greater effect in cluster headache, actually.
So I think with most new medications that are coming through for migraine, people are also really very interested in thinking, well, will this also work for cluster headache? So it sounds like the PACAP research might lead on to new drugs that could be potentially helpful.
Yeah, personally, I've always thought that PACAP-based therapies would be, really suited towards cluster headache. The science says that there's a very good chance that they'll be able to work on pathways that CGRP can't access in terms of cluster headache, but also then maybe down the line, and we're not there yet, of course, but thinking about combination therapies where we could look at approaches to tackle both of these pathways, the one that's related to migraine and the one that's kind of more independent from migraine, to see if we can get a beneficial effect. So there's definitely lots of research going on in this area, and cluster headache, I think, is the awareness around cluster headache is improving. So there's a lot of hope and potential there.
One of the things that I have wondered about, and people often ask about, is there any link between trauma to the head and developing cluster headache attacks? Because just occasionally you get somebody who says, oh, I had a bang on the head and after that I got... Do you think that's relevant?
Again, it's a complex area. I think there is some evidence, anecdotal evidence, that there are increased risks. So there's, of course, a genetic susceptibility, so if you have a family member, they're more likely to have that. There's evidence for some potential trauma, and it's something that's really intrigued me. I remember I was speaking to a young lady once who we were at House of Parliament for one of these things. We were looking to improve awareness around headache in general, and this was a lady, it wasn't cluster headache, but it was new daily persistent headache, and she had had a severe infection. She had had a sort of an infection and a viral infection, and recovered from that, but then this brought on her attacks, of course, and then she had this new headache. And I think we see that with a lot of different types of headache, that actually they can be these kind of predisposing factors.
Yeah.
And whether it's now that you would have developed that headache maybe later, or you were just at risk and this pushed you towards those attacks, it's hard to say, or whether it's definitely a cause like we would have with, say, secondary headaches, where we have, after a stroke or after some injury. That's really complex to say.
There are some lifestyle things that we're very keen to talk to patients about with regard to migraine, things like eating regularly, not letting your blood sugar slip too low, making sure that you have good sleep quality, sometimes taking certain supplements. There's not much evidence for any of those for cluster headache, but I am aware that smokers are much more likely to develop cluster headache. But unfortunately, there's no evidence that giving up smoking will actually improve your cluster headache. But at least if you're having oxygen, which is one of the gold standard treatments for cluster headache, you're not going to blow yourself up if you've given up your smoking. But are you aware of any other lifestyle things that we should be talking to people about? For example, alcohol, or drinking alcohol, or any
So I think
thoughts?
Yeah, cluster headache's that interesting one, going back to the fact that in migraine, that risk is kind of always there, so to speak, of having an attack. In cluster headache, we mentioned this switch. So, this in and out of bout. And I think it's really important then, we mentioned earlier on, for example, the nutrients, the vitamin D, magnesium, zinc, and of course, this is going to be individual to each individual person. You may tell from my accent, I'm from Scotland, and up there occasionally, although I'm living in London now, the daylight lengths get a bit short sometimes. And of course, depending on where you live and that access, you might need to be supplementing these different nutrients like vitamin D, looking at things that work for you. The complexity of this is that it is a rarer headache condition, so it's harder to get those big, large population level studies that we can get for migraine. And of course, what might work for one person won't work for another. So I think it's really important to look at your individual sort of attacks, and within reason, try the things that may work for you. Especially where, for example, in terms of nutrients, vitamin D, there's very low risk of anything, and can be used in conjunction with existing medicines. So,
yeah. I'm very aware when I first started becoming more of a headache specialist that the party line was that cluster headache was a condition of men, and that women rarely got it. But I think it's much more common in women, and of course migraine is much more common in women, so it's very easy for women who develop cluster headache, who also have migraine, for their cluster headache to be lumped in with the migraine, and for them not to be spotted quite so easily. I think we've improved in the rapidity of diagnosis as we've raised awareness of cluster headache, and so I would say yes, it's more common in men, but it's not that uncommon in women.
Yeah. So when I started in the field, very similar to yourself, I think that it was kind of largely thought that it was 3-to-1 male to female, but that number has definitely dropped now, and actually we're probably well under 2-to-1 now in terms of that relationship, and a lot of that's come from awareness and education, and that's a spin-off from migraine as well, whereby in the less sort of enlightened days, a female going to the doctor with headache may have been very quickly diagnosed with migraine and put in that pathway. And it's a really important diagnosis, because the therapies, well, again, there are some shared therapies like the triptans that can have benefit for both. Things like oxygen, for example, you mentioned this acute oxygen. So it's very high flow oxygen taken during the acute attack. And we've done the science on that. It doesn't touch migraine pain or headache at all. So it's very specific to cluster headache. So getting that right diagnosis can really help you get access to the right treatments.
Yeah. And with the triptans, of course, giving a tablet to a person with cluster headache, it's very often ineffective, but giving sumatriptan injections, or sometimes a zolmitriptan nasal spray, can be much more effective. And so it is, as you said, it's really important that people get the diagnosis, because the treatments are very in the same sort of ball game, but different for those different conditions. Yeah.
I think you've got to think about the dynamics of the attack. with migraine being this developing,
Yeah.
attack that can happen over many hours. Whereas within the bout, when you're having these cluster attacks, you're looking at much more rapid onset, offset attacks. So you're looking for things like the evidence for oxygen, for example, suggesting that it can work within about 10 to 15 minutes in patients to blunt that pain. A pill would just never, it wouldn't have the dynamics to get into the body and be absorbed in that time frame to be as effective. So we're really looking at those more faster acting therapies on board for these cluster bouts.
Yeah, so somebody I was speaking to the other day, he said, really, I said, how quickly does the pain come on? And he said instantaneously, and it's excruciating. So one of the things I've picked up from listening to patients and looking at various posts on forums and things is some people will try things like physical methods of plunging their head into cold water or standing in a cold shower. Very much as soon as they get the pain, they have to go and do this. Other people will take a drink like a Red Bull or a Monster drink, high caffeine drinks, very cold out of the fridge, and glug them down really fast. And then there are others who move on to the slightly more controversial things like magic mushrooms and psilocybin containing compounds, which as we were discussing before the recording started, we have to emphasize that these are not legal in the UK. And so people are dabbling things which are not confirmed by research, and people can get into trouble if they are found to be using these. But so a lot more research needs to be done onto these other therapies, I think, doesn't it?
Yeah, I think definitely. And we mentioned earlier about your individual attack, and it's really important to take on, to really think about your individual attack, because for some people, caffeine can be a benefit.
Yeah.
But for others, it can actually make things worse, especially if there's any overuse of caffeine and then subsequent withdrawal. So thinking about those things for you independently is really important. Thinking about, alcohol consumption. Are you sensitive to alcohol, and what types, for example, in terms of attacks? Taurine's a really interesting one, this kind of chemical that's in some of these energy drinks and different things, because actually we know that it can affect the brain metabolism. It can specifically affect this area in the brain called the hypothalamus, which is of really importance to cluster headache. And I describe the hypothalamus as, again, a bit like that thermostat of the body. It's the thing that measures what's going on inside your body and what's going on outside your body, and then adjusts your body systems and rhythms. So like, for example, making sure your sleep-wake patterns align with the light-dark cycle, because we want to be sleeping when it's dark and awake when it's light. So I think this hypothalamus is a really important structure, and it's not least so because it houses the master clock. So it houses the master clock in our brain that tells our body essentially the time of day and synchronizes those behaviors. And when we think about how the circadian and circannual, so when these attacks occur both during the day and across the seasons, that points to this hypothalamus being really important. And we know that things like taurine can affect this pathway and can affect the metabolism of that structure. So I think there's a lot of new research going on about how this hypothalamus, this place in the brain, might be affecting these attacks and controlling that onset of these bouts, and might even be, I don't want to say it for sure, but is this involved in that switching on and off of bouts? So that's really interesting. In terms of the other drug compounds, of course, again, as you mentioned, these are category A listed drugs in the UK, so we have to declare that with caution. But there is anecdotal evidence and research out there suggesting potential benefits, and I think this is where we need to get better. We need to now start to do the correct research to look at that. And one of the complexities of this is, in order to get a drug approved, of course, we have to go through a series of clinical trials, for example, starting with early trials, which are around safety in healthy individuals. Then we do some dose finding regimes, so what would be the appropriate dose? And then, of course, we look at population level trials to see how clinically effective is that compound. And we compare that against what we call placebo. So essentially a control drug that has no biological effect. And this is quite difficult in the area of, say, psilocybin or any of these molecules, because of course they have physiological effects like hallucinogenics that make them difficult to blind. So there's a complexity when working in this area around getting that government approval, shall we say, for in the US, the FDA, or in the UK, sort of NICE and regulatory approval that these medicines, because it's much more complex to compare them to placebo.
Yeah.
So again, it's an area that we need to do more research, but we need to do it in a different way from how we normally do clinical trials, actually, because we don't have such an obvious placebo that we can compare it against.
Yeah. Yes, it is a complicated area, isn't it? The other kind of group of drugs that I'm aware are used quite a bit in cluster headache management are steroids. And so sometimes people have oral steroids prescribed at the beginning of a bout, and sometimes they respond really well to a greater occipital nerve block, which is a local anesthetic and a steroid under the skin. And these also, the greater occipital nerve blocks are sometimes used in migraine to help people, but they seem to be particularly useful for some people who have cluster headache. Any thoughts about steroids?
Yeah, again, I think, so again, goes back to a little bit that shared biology of, for example, the greater occipital nerve. So this is a nerve that runs up both sides at the back of our neck, and it's involved in sort of innervation of the head as well. And of course, the theory being here that if we can block activity or dampen down activity in those nerves, for example, in migraine or in cluster headache, that you can reduce that sensory information to the head and kind of allow a reduction in attack susceptibility. In terms of steroids in general, I'm not so aware of evidence in this. Of course, they can dampen down inflammation a little and have an effect on that, and that in itself might have a beneficial effect. If you have any sort of pain condition, be that cluster headache, fibromyalgia, migraine, or any of these conditions, often they're made worse by comorbid pain conditions where there's probably some level of underlying inflammation or underlying inflammatory response. And it may be that dampening that down systemically is having an effect on, certainly maybe on the frequency of attacks that you're having.
Yeah. The other thing which is not widely used but is available is a neuromodulation device called gamma core, which is placed on the vagus nerve. And I'm guessing it's a similar sort of thing, isn't it? So finding a pathway to try and dampen down those sensory inputs that works in that particular individual. And there's nothing that I'm aware of that would absolutely work in everybody with cluster headache. It's a real sort of trial and error in much as the same as it is in migraine.
Yeah, we're certainly not there yet. We were at a stage of personalized medicine, and I think that's obviously a goal. And I think for both migraine and cluster headache, to be able to predict who will respond to these different therapies. I've personally done some work around the vagus nerve stimulation, and again, it's easy to say, but one of the problems with the vagus nerve is it's connected to everything. It helps with your heart, it's connected, so it's involved in so many different functions, and there is evidence now for episodic cluster headache that there's a benefit there in terms of, I'm trying to get that right, is it episodic or chronic?
Episodic, yes.
Episodic, yes. There's evidence for episodic, just to make sure we're giving you the right information, that it's beneficial, not for chronic cluster headache, unfortunately. But again, trying to tease out the mechanisms of that is really, really complex because it's so connected throughout our body. And it's quite interesting, actually, though, and just anecdotally, it's one of the main conduits for connectivity between our brain and our gut.
Yes.
So if you think back to this nutrient story and things and different components of lifestyle factors, that actually the vagal nerve is really that highway conduit between our brain and our gut. And there's evidence in migraine and different conditions that actually that gut health can really have a beneficial effect on the brain. Probably more generally than specifically related to, say, cluster headache, but never a bad thing.
Yeah. I'm not aware. We were talking earlier about women and cluster headache. And we know in migraine that the role of estrogen and hormones is very much a part of the whole picture. But I don't think that's quite the case in cluster headache, is it? I'm not aware of any kind of
we don't see any real association with migraine. We get this very clear association with the reproductive cycle and what we would term menstrually related attacks, where they worsen and become more frequent around menstruation. We don't see that so much in cluster headache, so there's not as much evidence for that actually in terms of that effect. So it's not something as linked.
Yeah. The other group that I'm aware of who increasingly aware of, and hopefully we'll be releasing some podcast episodes with this group, are children. And it is rare, quite rare in children, but not unheard of. So I'm going to be talking to some families who've experienced a child having cluster headache at quite a young age. So listen out for those, all you listeners out there. So Phil, can I just ask you, have you got a sort of, as somebody who commissions and directs PhD students into research, have you got a top 3 questions for research that you want answered?
Yeah, I think for sure. So my top one, and we're doing it at the moment in the laboratory actually, is trying to understand what that switch is.
Yeah.
Because actually we've been talking a lot about potential treatments and lifestyle factors, but if we can keep a patient out of bout,
yeah,
then a lot of that actually becomes, secondary, because actually we know you can't trigger when you're out of bout. So if we could understand what that switch is, and we've got some evidence that it might involve this hypothalamus, this brain area that our biological clock. So that for me is certainly the number one thing that we are looking at in the laboratory, and really trying to think about, rather than treating the acute attack, can we stop the attack from happening at all? And that then opens up a very interesting treatment perspective, where we look at treating based on the occurrence of those bouts. If we can predict how they're going to occur and when they're going to occur, can we look at different treatment models to try and prevent them?
Yeah.
And I would say for me, probably with cluster headache, it's one of those interesting topics, a little like migraine. There are several therapies that work. Things like, say, verapamil as the first line preventive, but we don't fully understand why.
Right.
And I'd say the number 2 thing we're doing in the lab at the moment is trying to understand, well, what is the actual mechanism of action that verapamil is working by in cluster headache? And the reason that's important is verapamil can have a lot of effects on the heart, for example. So patients have to be very careful about taking that for long-term exposure. If we can understand what its cluster headache effects are, independent potentially of those cardiac effects, then we can hopefully produce a much more effective therapy that has reduced side effects. So I would say for me, they're kind of the real 3 things that we're looking at. It's why bouts are starting and how can we stop that from happening. How we could treat based on bout prediction, a bit like being able to predict and look at when these attacks are happening. And perhaps maybe repurposing is not the correct word, but understanding how some of these more effective drugs actually work, so that we can develop, we've got modern techniques that allow us to develop new, potentially safer drugs. So actually, can we go and do that and develop new treatments that have a reduced side effect profile for these patients? So, and it all comes down to essentially being able to, give patients the tools that allow them to cope with these very disabling disorders.
Yeah. That's wonderful. And I think that gives hope to anybody out there who's listening who has cluster headache. Some of this research is already going on. There are people who are trying to find these answers, and hopefully over the next few years we'll get some new interventions that might make life easier for people with this intense and severe headache type. I'm aware that we're calling it cluster headache, and I was at the Ouch conference a while ago, and some people who have cluster headache were saying cluster headache is a bad name because it's so much more than a headache. It's such an excruciating condition. It is sometimes called the suicide headache because people feel so desperate with it. But Professor Goseby was there, and we all, were discussing all the different names that it's been called over the years, and some of them bear no relationship to the symptoms, but we're stuck with the name cluster headache, and it is what it is. I don't think we found anything that's more appropriate, but I think what we need to be doing is raising awareness of what a severe and impactful condition it is, so that people get diagnosed more quickly and onto the treatments that we do have that we know are effective.
Yeah, I think it's very striking, and I don't think we're being, we're not overstating it when we do say that. If you ask people report this as being worse than childbirth. This is one of the most severe pains known to humankind in terms of this cluster headache, and really being able to understand that and give people ways to cope with that, and potentially in time preventing it altogether, if we can reach our number one goal, is really going to transform the lives of these individuals. And, I really hope that we see that, we see progress towards that in the future. As you say, we have a number of wonderful students. I know you're going to be doing a podcast with one of my students this is a student who's going to be looking at individuals' brains and really trying to understand what's functionally happening within the brain in these patients compared to control and migraine, which is really interesting, allowing us to look across the conditions as well and maybe understand more about that link between the migraine and cluster headache and the association. So I'm looking forward to seeing this series of podcasts on cluster headache, and hopefully the next time we talk, maybe we can have look at in the future what's progress since this last talk.
Yes. Well, Phil, thank you so much again for giving up your time and coming on the podcast again. And we'll speak to you again soon, hopefully.
Thank you very much. It's been a pleasure.
Coming up next time on Heads Up, neuroscientist Izzy West shares her personal experience of living with cluster headache and the research she's undertaking to better understand the condition. Thank you for listening to the Heads Up podcast. Visit our website to book your appointment with a world-class headache doctor wherever you are in the UK. There is no need for a referral. You can refer yourself. Our headache specialist doctors are looking forward to helping you soon.